Myasthenia gravis is actually a that ought to wake you up, is actually considered a grave muscle weakness type of a disease. It is a chronic autoimmune neuromuscular disease that destroys the acetylcholine receptors at the neuromuscular junction. And typically the signs and symptoms are going to be weakness and fatigue of the skeletal muscles, and this is due to a defect in transmission of the nerve to muscle impulses. The cause is not typically known. It's some sort of an autoimmune response that destroys many of the acetylcholine receptors at that junction. We see it more often in women than men, and the onset tends to be in a younger population between 20 and 30. And there's research that's noted the thymus gland plays a role in the development of this disease. About 75% of patients with MG will have thymic hyperplasia. So they will have many exacerbations and remissions also with this disease. This is a slide that just depicts how those neuromuscular junctions are changed due to antibodies on the receptor proteins. And these receptor protein antibodies are actually found in up to 90% of all people that have MG. So they bind to these receptor sites and then make them unavailable to be able to bind with the acetylcholine that's actually released from the nerve ending. The signs and symptoms are going to include abnormal fatigue of voluntary muscles, typically around the mouth, eyes, respiratory area, and arm and leg. These patients are unable to sustain repeated muscle contractions, so you may actually see drooping of the eyelids, which is ptosis, and then facial muscles that become very weak, so they have trouble smiling, speaking, chewing, or swallowing. As the disease progresses, there's going to be difficulties with muscles of the neck and the extremities. The precipitating factors are unknown. Once again, it's thought probably the thymus hyperplasia perhaps happens due to a viral infection the patient has, and then that virus causes a production of antibodies that destroy the thymus gland. So this would kind of be a similar theory to what we talked about with type 1 diabetes, as far as a virus attacking the pancreas and the being able to produce insulin and that type of a thing. It's also, interestingly enough, there's a very strong association with hyperthyroid. Some patients that have hyperthyroid go on to also develop myasthenia gravis. It's also been associated with thyroid tumors, rheumatoid arthritis, and systemic lupus erythematosus. Some other factors that can trigger an exacerbation are listed here for you. So infection, surgery, stress and emotional upset, temperature extremes, physical activity increases, pregnancy, anesthesia, and medication interactions. So particular meds with MSO4, hypnotics, sedatives, and certain antibiotics. So what do you need to assess for specifically with these patients? One thing that we need to look for is that ocular muscle weakness we talked about earlier. That patient may have double vision due to ptosis, difficulty closing the eyes, blurry vision, that type of a thing. They may also have bulbar, which is head and neck, muscle weakness, which will lead to speech and swallowing problems and problems speaking and that type of a thing. Respiratory muscle weakness may appear, signs and symptoms wise, very similar to restrictive lung disease, and they may also develop skeletal muscle weakness where they'll have problems with fine motor movements early in the disease, and then it will progress to major motor weaknesses later in the disease. Weaknesses typically will increase with exertion and maybe improve slightly with rest. So how is it diagnosed? We do an acetylcholine receptor antibody titer lab test. If this number of antibodies in the serum is increased, that's considered positive for MG, and this is accurate in about 80 to 90% of clients. Another thing that's done is what's called a tensilon test. The patient is injected with a medication called tensilon IV. If there's improvement noted in the muscle strength that lasts about 5 minutes or so, that's positive for myasthenia gravis. And then the third thing that's done is the patient will have an electromyogram done, which can look at delays or failures in the neuromuscular transmission to muscle fibers. So this can actually measure the response of cholinesterase inhibitors, neostigmine, and those types of things. So back on the Tensilon medication, typically most patients that have MG will show a quick improvement in muscle tone after this med is given, because what it is, it's a cholinesterase inhibitor. And remember, cholinesterase is actually what breaks down acetylcholine. So if we give a cholinesterase inhibitor, such as Tensilon, it allows more acetylcholine to be on board in that patient's body. So if the patient would happen to get worse instead of better after this particular medication, in other words, they had a negative test for MG and their muscle weakness was due to something else, the antidote for this drug is atropine, and that can be given. So medical management for MG is going to focus on treatment of the symptoms, especially the progression to respiratory problems, and also meds to control the symptoms that they have. Typical meds that are used are going to be including anticholinesterase meds such as neostigmine and mestinon. These are two common meds used. Neostigmine actually helps with the transmission across the neuromuscular junction and will also inhibit destruction of acetylcholine. Mestinon inhibits destruction of cholinesterase and will enhance the effects of acetylcholine on the skeletal muscles. Steroids are also helpful. They help to immunosuppress the body. Remember the antibody formation that's going on. And they also help to improve muscle strength. Sometimes patients are given adrenocorticotropic hormone for 10 days and then prednisone. They give that in high doses and then taper it to the lowest possible dose that the patient can have relief of symptoms but still tolerate the medication and those types of things. So side effects of these medications that we talked about earlier, mestinon can cause a lot of cholinergic side effects, and those would include like nausea and vomiting, abdominal cramping, diarrhea, urinary urgency, bradycardias, bronchospasms, sweating, increased salivation, twitching, those types of things. So remember, cholinergic side effects are due to similar to what a parasympathetic type of stimulation would be. So we see those types of effects. Sometimes the side effects of this particular drug is helped if the patient takes it with a light snack like milk and crackers or something like that. That seems to help a little bit. Other information that patient needs to know about their medications are that they need to be given in minimal doses to get the maximum improvement. They should be taking the medications about an hour before they take a meal so that it has the peak effects when they're trying to chew and swallow. The oral dose, typically the onset is in about 30 minutes and then it peaks in 2 hours and lasts about 3 to 6 hours. So it's very imperative that that med needs to be given on time. The patient should take some sips of water before the meds and make sure that they're not having swallowing difficulties before they try to swallow the pill, because we don't want them to aspirate or choke on it or anything like that, because remember all the facial muscle weaknesses that happen with this drug. Some signs and symptoms of toxicity are going to be increasing weakness and twitching 60 minutes after the meds. So if the medication dose is too high for that patient, they need to report those types of symptoms to their physician to have their medication adjusted. Patients with MG can actually go into two different types of crises. One is called a myasthenic crisis. This is due to an undermedication of the medication, so of anticholinesterase meds. And the symptoms the patient will develop are severe muscle weakness, changes in vitals, anoxia, cyanosis, incontinence, absent cough, and swallowing reflex. And for these patients, we can check to see what kind of crisis they're in by the Tensilon test. If they're in myasthenia crisis, then that means that their medication level is too low and the Tensilon test will be positive. For patients in cholinergic crisis, it's due to an overmedication of the anticholinesterase meds. and they will also have similar symptoms of muscle weakness and those types of things, but when given the tensilon test, it will actually be negative. So that is the way to differentiate between what type of crisis this patient has. So just a quick review, with the tensilon test, there will be a temporary relief in the myasthenia crisis, and it may worsen a cholinergic crisis. So to treat the crisis, the patient needs to be watched for respiratory failure. They may need to be put on a vent while they're in crisis. They may have a lot of oral secretions, which can be treated perhaps with atropine. They may need plasmapheresis and also neostigmine IM or IV. So the nursing situation that we have with this particular case scenario is going to be a 74-year-old retired social worker who was admitted several days ago for plasmapheresis, and symptoms include muscle weakness in the lower extremities, diplopia, which is double vision, and hand weakness. So the patient is going to be a good candidate for plasmapheresis. Plasmapheresis, this is used when the client does not respond to meds or surgical treatment. Typically these patients that have a new onset of myasthenia gravis will have their thymus gland removed. So plasmapheresis might be used for that patient in the interim. Also, they will use plasmapheresis when the respiratory muscles are involved. The goal is to remove the antibodies that are attacking that neurojunctional muscle site and destroying the acetylcholine receptors to try and improve muscle strength, to decrease fatigue and other symptoms. And typically what happens is a plasma exchange with donor plasma. They need some sort of a large bore access to do that, such as a Quinton catheter, and you can refer to your book for nursing responses. Plasmapheresis takes around 2 to 5 hours to complete. There's a special type of a unit that's actually used for plasmapheresis, and the patient will typically have this done for 10 to 15 days. There's a picture in your textbook of a plasmapheresis machine, so please refer to your textbook for that. Some good calls for nursing are ineffective breathing pattern and airway clearance, problems with nutrition. They're at high risk for injury related to sensory perceptual changes. There's also issues with self-esteem, physical mobility, and knowledge deficits. So surgery, like we mentioned earlier, may be a possibility. They may remove the thymus gland, and that can cause remission of the disease in about 40% of all the clients. It may prevent formation of those anti-receptor antibodies for the patients that have had it removed. Typically, they'll have that surgery done within 2 years from the onset of their symptoms in order to get the most improvement. And refer to your textbook for nursing care of a patient who's had a thymectomy done. So when can they actually be discharged? Most patients with this disease are managed at home. They can be discharged when treatments are completed and the meds are regulated. And just another little feature to keep you awake during this lecture, they may require extended discharge planning. So home health care may be set up for these patients to make sure that they are taking medications as prescribed, and we can get them into community resources and social services to help out with their issues. So NCLEX question number 1 is the nurse is teaching the client with MG about prevention of crises, and the nurse tells the client that this is most effectively done by which of the following? And if you answered number 2, that's correct. Remember, it's most important for these patients to take medications on time. They need to try and time the medication dose with the peak of when the med will occur with their eating so that they don't have issues with aspiration and trouble swallowing. The second NCLEX question looks at the client with MG has a risk for ineffective airway clearance. The nurse keeps which of the following available at the patient's bedside. Remember, they can go into respiratory failure, so always have an ambu bag and suction equipment ready to go for these patients. And this concludes the lecture on myasthenia gravis.